of time, let me call upon Dr. Kirti Singh ma'am to take her first talk that's beyond IOP. Dr. Kirti Singh ma'am is a teacher par excellence and a facilitator and mentor. And of course, she needs no introduction in the field of glaucoma.
Hello. Thank you, Dr. Shweta, for that kind introduction. Mic please check karna hai. Do you have a pointer, please? Thank you. So we just had a glaucoma session and another glaucoma session, and I thank AIOS and the Ajanta team. So my topic given to me by the team was Beyond IOP. I'll be covering vascular primarily and some neurological aspects of glaucoma. Now we all know that retinal and optic nerve blood vessels have no autonomic innervation. Unlike the strong autonomic input to choroidal blood vessels, these vessels depend on autoregulation. And basically in glaucoma, what happens in the vascular aspect is that there's disturbed autoregulation or dysregulation as we call it, and that causes ischemia and reperfusion damage. Decreased blood flow velocities in both short posterior ciliary artery, central retinal artery and retrobulbar vessels have been documented, with increased indices of resistive index and decreased blood flow being documented with faster progression. The basic concept is perfusion instability. So let's come to this. All these evidence for ocular blood flow came from landmark studies of EMGTS, CMTTS, which said that despite IOP control, glaucoma could progress. And then these multiple studies of Egna, Newmark, Baltimore, and Proyecto studies, and especially the LAIL study, came up with the concept of perfusion pressure, where the systolic blood pressure and the diastolic pressure reduction or the systolic pressure increase was linked with glaucoma. And the perfusion pressure concept came in that less than 50 millimeters of mercury, and some say 55, but there's no hard and fast figure, increase the risk of developing glaucoma 4 times. So much so that ocular blood flow came to be in the consensus series 6 in 2009 that compromised ocular blood flow, primarily low ocular perfusion pressure of less than 50 to 55, and deranged vascular autoregulation in optic nerve head was identified as independent risk factor for glaucoma progressions. The formula given for OPP is pretty confusing, but what we normally use is the diastolic OPP, or the DOP as we call it, diastolic blood pressure minus IOP, which should be more than 55 or 50. Now let's come to vascular dysregulation. There are 2 types, primary and secondary. We will all know about the secondary with rheumatoid arthritis, temporal arthritis, Raynaud's phenomena, and multiple sclerosis, where the endothelial levels go up and the glaucoma incidence and prevalence and progression both go up, especially the NTG variety. But what we don't know about much is the primary vascular dysregulation, or the Flemmer syndrome. Usually type A personalities with cold hands, cold feet, migraine, reduced thirst, systemic hypotension, especially at night. This problem starts at puberty and improves at menopause, seen commonly in females. This is very highly linked with normotensive glaucoma. The other aspect is the blood pressure. That's a big player. Let's talk about some aspects of blood pressure. One is the nighttime dip or the nocturnal dip. It is both physiological as well as non-physiological. Physiological can be the systolic blood pressure dips by 10 to 12%, diastolic by 14 to 17%. It happens in 2/3 of normal individuals. You and me, normal individuals, 2/3 of us will have that physiological dipping at night of the blood pressure. Non-dippers also are there, which have a declined or absent or blunted dip, less than 10%. This does cause impaired microcirculation, increased toxic free radical production, and especially if the person has hypertension and there is no nocturnal dip, or it's a non-dipper, increased risk of CVC events, cardiovascular events. However, there are otherwise non-physiological dippers which have extreme dip of blood pressure, more than 20%. Physiological non-dippers is less than 10%, and non-physiological are more than 10%, and they have been identified with visual field progression. So one was the night time, and second is the night posture, sleep and posture. There's a circadian peak at night, IOP peaks at night, early morning. We know that by our diurnal studies, and causes increase because of increased outflow resistance. BP as we just discussed, there's a nighttime dip. So there's a perfect storm of low ocular perfusion pressure with reduced ocular nerve head perfusion at nighttime. The second thing is the posture. Sitting IOP is less than supine IOP, even at sleep time, and sleep posture influences with a 30 degrees head-up position vis-a-vis flat position, causing a reduction in 3.2 millimeters. Again, these figures are obviously not hard and fast, but what it means is that sleep posture does influence the IOP. Almost 20% reduction in 35% cases with no differences in blood pressure. You would assume that it would be related to the blood pressure, but this is IOP reduction per se. And so obviously these people sleeping in the railway station have a right point that they have raised their heads a little bit. So that sleep posture is important. Then the next thing is obstructive sleep apnea syndrome. OSAS has been linked with compromised optic nerve perfusion because of transient hypoxemia. OSAS patient with no glaucoma history have thinning of retinal nerve fibers, choroid and macula. Negative correlation has been seen with apnea-hypopnea index. And obesity supine position has been linked with increased intracranial pressure. And the treatment for OSAS is continuous positive AFA pressure therapy, which itself will increase the IOP. And this has been linked to be, again, independent of intraocular pressure. This OSAS studies with the blood flow. So as you can see, snoring, obesity, if it's there, that's another risk factor for normal tensive glaucoma. Other systemic conditions affecting the ocular perfusion are hypertension, we know about that, diabetes, Raynaud's phenomena, migraine, episodes of hypovolemic shock. It's just not hypertension actually, it is more of hypotension. And hypercoagulable states, obstructive sleep apnea, new buzzword, and thyroid disease, and systemic medications, of course. So there are other vascular conditions which are affecting the ocular blood flow. Hypertension, both coexist because both are in elderly patients. Each 10 mm increase in systolic blood pressure has been linked with 0.3 mm increase in intraocular pressure and impaired ocular perfusion because of the altered epithelium sodium transport, which causes kidney problems as well as ciliary body epithelium issues. This LAIL study is a beautiful study which you can go up and read up, almost in 6,000 patients with hypertension, no hypertension, OHE, where they identified that 10 millimeter increase in systolic perfusion pressure with blood pressure was linked with 0.33 mm of increase in IOP, and both systolic and diastolic, let's not go by the figures, but both systolic and diastolic were linked with increased IOP, and low perfusion pressure again was reiterated as being the critical factor. However, there are naysayers, and the Beijing Eye study on adult population not using anti-glaucoma medications did not find any link of open-angle glaucoma with systolic or diastolic blood pressure. In our studies, we have been doing ocular blood flow for the last 15 years with our Department of Radiology, and we did show that this patient who had a reduced ocular blood flow in asymmetrical glaucoma, after trabeculectomy, the blood flow dramatically increased. CSF pressure is a new player, translaminar cribrosa pressure difference, and now glaucoma, the optic normal tension glaucoma can be thought of as putative optic nerve sheath syndrome, that is diseased optic nerve in CSF environs. Link with chronic neurodegenerative conditions like amyloidopathies, and has been linked with cholinergic transmission, which has given rise to the choline injection and drops as putative treatments for glaucoma. So much so that a glymphatic system has been identified which is common to Alzheimer's, Parkinsonism, and glaucoma, and this dysfunctional system reduces CSF pressure in glaucoma, and that is what is causing the reduced perfusion pressure. Many studies disprove age as being the primary cause, and we all know about meditation and the CNS effects on glaucoma. So when do we go looking for these things? Do we actively go and look for neurological or the blood flow problems? Neurological evaluation in normal tension glaucoma, are they worth the effort? This study said no. Only when you have red flag signs, when you have glaucoma younger than 50 years, poor visual acuity not commensurate with the glaucoma, neuroretinal rim pallor too much, visual field defect again not commensurate with the disc damage. These are the red flag signs. So clinical take-home messages, hypertension if the patient has, which is again very common, avoid over-medications, diastolic blood pressure should not be lower than necessary. If nocturnal dip is there, BP medicines need to be shifted from evening to morning. Try to do a phasing where 24-hour BP check and controlling and do a diurnal control. meds, carbonic acid inhibitors, and the aspects which work at night may do better, and try to avoid the drugs of the blood pressure at night. Thank you so much. If anybody of you who wants to read these, you have the Arctic Major Review in DGO. Thank you.
Thank you, ma'am. Indeed, it was a very nice presentation. Ma'am, there is one question. How often do you ask your patients to undergo sleep study once you see that they are progressing? So what is your first diagnosis? Do you take it as a diagnosis of exclusion?
No, sleep studies, number one, I don't have the facility for doing sleep studies. What I do have the facility of doing is the diurnal control of pressure or diurnal variation. So I do a diurnal control where I do a phasing, where I measure the blood pressure at different intervals, including the early morning at night and the IOP. Only for those patients who have obesity, who have the sleep apnea syndrome, and then they get the sleep studies. But again, it's not possible for me to monitor the sleep apnea at night because of the environment. But these are new things coming up. Basically, it's all lifestyle. Reduce the obesity, have a proper posture, circadian rhythm, it goes back, sleep in time, sleep well. This is basically all that, which is the nutshell which comes up to.
Yes, ma'am. Thank you, ma'am. Now, may I call
Shweta, just for sleep, the American Chess Association has a very nice top bank questionnaire. It's a very simple 8 questions, and each has one score. So anybody who's in more than 3 is suspect, more than 5 is definite obstructive apnea.
Yes, sir.
So, and I don't know in other cities, but I'm sure Delhi, Mumbai, definitely there are lots of centers who do the sleep study.
Okay, sir.
Yeah,
And,
but in my center, I
it
don't
comes
have that.
with the,
Of course, it's done. Sleep. A lot of centers are doing sleep
yes,
studies.
lots of
Especially the
centers.
pulmonary people,
So
they are doing
you can,
sleep
in fact,
studies.
Mumbai, so there are people who they go to the home sleep study also. So they go home, give the machines. The next day they take machine with the data,
Yes,
and within 3-4 days they give the results. So
Sir, and
it's-
what is your experience regarding getting this sleep study? How frequently do you recommend?
So what we do, the patients who are progressing with the normal IOP, first we do the diurnal pressures, and I take the effort to check the pressure myself at the night. We admit in the nearby hospital. I check the pressure at night and early morning. If the pressures are normal, then or if the stock bank questionnaire shows more than 3, those patients I send for the sleep study. And lots of patients, I'm not talking only glaucoma perspective, overall perspective, the improvement is significant because studies have shown that their systemic disease also get well controlled once their obstructive apnea is under control. So it's really beneficial.